So tonight's lecture is One Size Fits One, a new way to practice children's medicine from Professor Somnath Mukhopadhyay and Dr. Tom Ruffles. Professor Mukhopadhyay is chair in Paediatrics and Dr. Ruffles is clinical senior lecturer and honorary consultant in Paediatric Respiratory Medicine at BSMS. They have an interest in new ways of tailoring treatments for children's asthma and allergies to produce better results. So on that note, I will hand over to our lecturers this evening.
Thank you very much, Zach. It's an absolute pleasure to come to this meeting and welcome all. One Size Fits One. It's a funny title, isn't it? And the reason we've called it One Size Fits One is hopefully going to become apparent in the next few slides. And that's really, really important because that's what leads to the rest of the discussion for today. Now, my name is Somnath and I am Professor of Pediatrics and I'm an asthma doctor. I'm a children's asthma doctor, and so is Tom Ruffles. So both of us are, and we work very closely together. And we also work very closely together on this One Size Fits One theme. So what's so important about asthma? Really, the first thing to ask is why? Why are we thinking about asthma? Well, and let me see if I can move my slides, which I can't at the moment. So, yeah, I can now. Now, these are two quotes from patients with asthma, children with asthma. And this is just to make you think of asthma. And as I said, these are two quotes to make us realize, to make us think of how difficult this disease is. And I don't need to read them out. You can see what it means to a child. If you can't climb the stairs, never mind going outside to play, and every child wants to play. So this is how important asthma is. It causes tightness of the airways, and the airways react to all kinds of different substances. They might react to pollen, they might react to food, they might react to God knows what, and the airways constrict, and it causes problems immediately, and it can cause problems long term. So the fact that it causes problems immediately in the moment means that you have to use a medicine called a reliever to get things better. The fact that it also causes problems longer term with these immediate spikes of attacks means you have to use another set of medicines called controllers, which will maintain control in the longer term. So there are generally two groups of medicines that are used in asthma. I'll come back to that in a moment. And that is really where the one size fits one versus one size fits all discussion comes in. How common? Well, I already mentioned 1 in 11 children. So about 1 million children in the United Kingdom alone have got asthma. It's a common cause of school absences, one hospital admission every 21 minutes. These are just a few facts and figures to make us all sit down and think, oh, wow, this means it's really, really common. And many patients report inadequate response. I'm taking my medicine, I'm taking my reliever medicine, I'm taking my controller medicine, but I am not getting better. And there are studies, relatively recent studies from the United Kingdom, from big cities like London and Leicester, where you find that 30, 35, 40% of children have an inadequate response to their medicines. They are not responding well. They are getting sick much more than they would ever want to be. So £1 billion is a lot of money, isn't it? This is actually quite old data. If anything, it's gone up. And you can see that 50% of the money is spent on what is known as unscheduled care. And what scheduled care is, okay, going to the doctor, getting a checkup once every 3 months, once every 6 months, going to the nurse, getting a checkup. Unscheduled care is right in the middle of the night. I'm getting tight. And what am I going to do? Well, if I'm a little child, I'm going to plead with my parents to take me to hospital or to call in the doctor. And this is how unscheduled, and it can be really, really, really frightening. It's going to be a frightening experience for the child and actually a very frightening experience for the parents. So a lot of money is spent on hospital care, on GP care, because the GP is very tight with appointments, as we all know, and yet these children have to be seen by the GP urgently. And 50% of this money is actually spent on children. So although children are a smaller proportion of the overall population of people living in the United Kingdom, 50% of this money is spent on children. Children are more likely to have this kind of unscheduled care. And the question that is really important is whether asthma and allergy are conditions that are still poorly controlled. I mentioned asthma and allergy because allergy and asthma go hand in hand. Are they still poorly controlled because we have adopted a more or less one-size-fits-all approach to treating this problem? And at this point, he will say, you haven't explained what is the one-size-fits-all approach. We have been talking for 5 minutes. Well, here we go. Let's see if I can move the next slide. Yeah. So this is what I mean by the one-size-fits-all approach. And you don't have to go through this horrible slide that I've put in front of you, because you're going to learn all about it when you're studying medicine. This or similar slides, trust me, you will have pretty much all children follow this wise ladder formation system. Many of us think we don't think carefully enough about the individual child. What the child's needs are, whether individual medicines aren't working in a particular child, using medicine A or medicine B in a child, or you might be medicine C, 2, 3, 4 different medicines, and it's not working. But do we stop to think whether or not these medicines are actually making a difference to the child? Should we be stopping? Should we be changing one medicine for the other? And Dr. Ruffles will come back to you more on this, I think, very interesting subject. So I will leave that for him. He is going to come back. He's going to do the second half thing, something else.
Hi, Somnath. Sorry. I think your internet is a little bit unstable. So what I'm going to do is I'll start sharing your slides. And if you just tell me when to go on to the next one, that will hopefully take the pressure off of your internet a bit. So what I will do is I'll jump on. Just let me know when you want me to move on to the next slide.
That's perfect. Great. Next slide, please. Yes. So this is a simple pictorial representation that I tried to get there for you for the one-size-fits-all versus one approach. A one-size-fits-all approach for everyone, whereas a one-size-fits-one approach that holds right for one group of children, whereas there is a different approach for group 2, a different approach for group 3, a different approach for group 4, and so on. So different approaches for different students. Will I still be using it for the Bright Ideas program? Well, that's a question for Zach. I'm sure he can answer it for you in the chat. We will move on to the next slide, please. So this is one story that we think is really, really important within the one-size-fits-one approach. And here is a picture of the skin. It's a microscopic section of the skin. And you can see that there is a picture with lots of black areas on the surface, and side by side there's a picture with very few black areas on the surface. These black marks are areas where a particular protein called filaggrin is being stained. So the section to the left was taken from one patient, section to the right was taken from a different patient. And you can tell that the patient on the left side has filaggrin granules because they have all come up nicely and stained black. On the right side, the patient does not have the filaggrin granules, and that's why it's all the kind of blue, and there is no black in there. That comes out from a stapler. And a stapler, what does a stapler do? A stapler holds sheets of papers nicely together. Yes. A stapler holds lots of pieces of paper nicely and tightly together in a sheath and keeps all the papers in place. Just like that, our skin is made up of sheets of keratin, and the sheets of keratin are held together by the staple, and that staple from the stapler is the filaggrin molecule. It holds the sheets in place nicely and tightly together, and that means the skin barrier, the barrier of the skin is tight, and allergens that cause allergies cannot go into the skin and cause allergies, sensitize us. Now, 15% of children we found have got a genetic change, which means that their filaggrin protein does not function well. And if the filaggrin protein does not function well, and you will not be finding it on the you might not find it altogether, or you might find a little bit of it, but it's not there in the kind of quantities that it should be, and it's not working well. And as a result, the staples are not fixing the keratin sheets together nicely and firmly. The keratin sheets are fuzzy, and the allergen particles can come in, and they can come in right from the point the baby is born, and they can begin to sensitize the baby and cause eczema, which can often lead to asthma or be very closely linked to asthma. So this is one way we think, a lot of people think that this is one way you can cause eczema. You can also get worse eczema, and you can get worse asthma too. Next slide, please. How does that? And this is just a diagrammatic presentation of the same story. You can see on the left side, healthy skin, where the allergen particles are bouncing off, a skin with malfunctioning filaggrin, where the allergen particles are going in, activating the immune cells, leading to asthma and allergy and eczema and allergic rhinitis, which is allergic nasal problems and such like. Next slide, please. So imagine what we have been just discussing, the situation where you have got 15% of children who have the skin barrier defect, 85% of children who do not have a skin barrier defect. Here is the question. Here is the problem that we are going to start pondering about a little bit. 15% have the skin barrier defect. We know they've got a genetic defect, which is making them much more likely to develop eczema and asthma and such like. 85% don't. And this 15%, you find, and it is indeed true that there is quite a lot of evidence, although it's not been fully studied as yet. There is a lot of evidence to suggest that you can use some simple medicines which are like cetrimide containing emollients, which can protect the skin barrier and which can make the skin barrier stronger. If the skin barrier is weak, it can make it stronger. It can reduce the entry of allergens through the skin. So this is the question I'm going to throw at you, and you can have a think about what your answer will be. If there is a medicine that helps protect the skin barrier, and in this way reduces the impact. You know what reduces the impact? It is reduces the possibility of children getting eczema and asthma, either getting the disease or getting worse disease. Would you use this medicine for all children to make their asthma better, to make their eczema better? Or would you do a gene test or skin test maybe first to pick up the children who have the skin barrier defect and use the medicine only on those children? I can already see Abigail has given an answer. Do the test first. And Ariba Akhtar says, and so does Faith say, brilliant. You have just discovered one size fits one, guys. This is the future. You're going to be building the future of personalized medicine. And it's not just me sitting here trying to say this. You are a bunch of really clever guys. You should all get into medicine. Final word. Let me move to the next slide. Next slide, please, Zach. Okay, so this is not just me. This is not just me waffling away. This is the whole world trying to tell us doctors and future doctors. Yes, Ariba Akhtar, why do doctors still give eczema still give steroids for eczema even though it leads to tropical steroid? Well, all these questions are part of the precision medicine story. You're absolutely right. And to discuss this and take it forward, do join. You will find the logo there. One size fits one. Join. Olivia Cottington will help you through this story. She's already in the chat. Olivia, so they can all. She's our engagement coordinator, and there you go. That's Olivia for you. So join us on, and indeed we have a special event. We have a special everyone's program on the 1st of September, Sunday the 1st of September. All the details are on that Instagram, one size fits one size. Coming back to what I was saying, and this is my final point before I hand over to Tom for the second half of the talk. It's not just my idea. Simon Stevens was the chief executive of NHS England, and he has been described as one of the most powerful men in the NHS ever since the NHS was founded. And what did he say in his inaugural speech? It's worth pausing for 15 seconds to read through it. From carpet bombing to precision targeting, from one size fits all to one size fits one. The NHS should be at the forefront of this global medical revolution. So common diseases, and this is a really important sentence, so common diseases may in fact be extended families of quite rare diseases. And then he talks about how also patients and communities should play a role. And that, again, is a very important part of the introduction of personalized medicine into day-to-day healthcare. So as you can see, the top people, next slide, please. This is my final slide. Next slide, please. The top people, and not just the top people in the NHS, this you will all recognize is one of the presidents who have been extremely popular right across the world. Presidents of the United States, Barack Obama. Barack Obama, I can't remember the exact money, 100 million or so, invested in the precision medicine program of the United States. All over the world, right from the top, there is a strong drive to introduce precision medicine. Over to you guys. You're going to be the next doctors of the future. You will have to take it forward over the next 50 years. Thank you very much, and thank you for listening. I shall hand over to Tom now and stop sharing the screen. We will leave questions to the end, I think, and just let you guys digest, if that's all right with everyone. Thank you.
Grand. Hopefully you can hear me. Maybe a thumbs up from someone if they can. Perfect. Right. As I was kind of introduced, Tom, I'm one of the paediatric respiratory doctors working in Brighton, and I will try and rattle through things. And with just the brief outline of what we're going to discuss. So, what is asthma and why is it important? I know someone that's already covered that to a degree, so we'll keep that tight. Current approaches to asthma management, what kind of actually personalized medicine genotype-directed therapy means, and then where have we got to in trying to get this into routine care. So someone that's already covered this, there's already quite a few people in the audience have got a personal experience, or they know people who have asthma and whose lives has been impacted. And as just a short TED Talk here, video, because I do appreciate that not everyone will fully understand what this is. Hopefully this should play. Or not. It seems like the embedded link has not wanted to play, so we'll just play it straight through and hopefully.
There's finally a better way. It's called Otter. Let's say I'm in class. I just hit record, and as you can see, everything I'm saying
It starts with a cough or a wheeze. Soon, your chest feels tight. Your breathing speeds up and gets shallower, making you feel short of breath. These are common symptoms of an asthma attack. Around the world, more than 300 million people suffer from asthma, and around 250,000 people die from it each year. But why do people get asthma, and how can this disease be deadly? Asthma affects the respiratory system, particularly the smaller airways, such as the bronchi and bronchioles. These airways have an inner lining called the mucosa that's surrounded by a layer of smooth muscle. In people with asthma, the airways are chronically inflamed, which can make them hyperresponsive to certain triggers. Some of the many asthma triggers include tobacco smoke, pollen, dust, fragrances, exercise, cold weather, stress, and even the common cold. When people with asthma are exposed to these triggers, an asthma attack or exacerbation can occur. But how exactly do such everyday factors lead to an asthma attack? If an asthmatic is exposed to a trigger, the smooth rings of muscle that circle the small airways in their lungs contract and become narrow. Simultaneously, the trigger worsens inflammation, causing the mucosal lining to become more swollen and secrete more mucus. Under normal conditions, the body uses this mucus to trap and clear particles, like pollen or dust. But during an asthma attack, it blocks the narrowed airways, making it even harder to breathe. These effects lead to the symptoms of asthma. Smooth muscle constriction results in the feeling of chest tightness. Excess mucus and increased inflammation can cause coughing. And the wheezing noise? That happens because as the airways constrict, air whistles as it passes through the narrowed space. These symptoms may make a person feel like they're running out of air. Yet counterintuitively, during an asthma attack, the inflammation can make it harder to exhale than inhale. Over time, this leads to an excess of air in the lungs, a phenomenon known as hyperinflation. The trapping of air inside the lungs forces the body to work harder to move air in and out of them. Over time, this can lead to reduced oxygen delivery to the body's organs and tissues. Sometimes, in untreated severe asthma attacks, the body can't keep up, which can lead to death from lack of oxygen. So how do we prevent these uncomfortable and potentially fatal attacks in people who have asthma? One way is to reduce the presence of triggers. Unfortunately, the world is an unpredictable place, and exposure to triggers can't always be controlled. This is where inhalers, the primary treatment for asthma, come in. These medications help asthmatics both control and prevent their asthma symptoms. Inhalers transport medication along the affected airways, using a liquid mist or fine powder to treat the problem at its source. They come in two forms. There are reliever medications, which treat symptoms immediately and contain beta agonists. Beta agonists relax constricted muscles, allowing the airways to widen so more air can travel into and out of the lungs. The other form of inhalers serve as preventive medications, which treat asthma symptoms over the long term and contain corticosteroids. Corticosteroids reduce airway sensitivity and inflammation, so asthma can be kept under control. They're also crucial in preventing long-term damage from chronic inflammation, which can cause scarring of the airways. Inhalers are known to be very effective and have helped many people live better lives. Although we've come a long way in improving how we treat and diagnose asthma, we still don't know its exact causes. We currently believe that a combination of genetic and environmental factors play a role, potentially acting during early childhood. Recent research has even linked poverty to asthma incidence. This may be due to reasons ranging from exposure to additional pollutants and environmental irritants to difficulties in obtaining medical care or treatment. As our understanding of asthma improves, we can continue to find better ways to keep people's airways happy and healthy.
Hopefully apologies, the previous link worked fine, but for whatever reason it wouldn't. So just recovering really what is asthma and why it's important. I hope that video just kind of explained it for those people that don't have that experience with it. It's a term that describes the symptoms of wheezing and coughing and chest tightness. And as the video said, the pathophysiology, the underlying issue is you've got lots of inflammation in the chest, you've got lots of mucus, the muscles get tight, and then they're hyper responsive. Those airways, those medium-sized airways and smaller airways are hyper responsive to triggers that otherwise wouldn't cause an issue in other children. Those risk factors we're talking about, genetics, seem to play a really important part. Allergies, being born premature, pollution, tobacco smoke, obesity. And those triggers, as we were talking about, also the things that are going to exacerbate young people and make them worse are things that you know about. Things such as smoking, exercise, cold weather when they get infections. But why is it important? Well, as Somnath said, it's the most common long-term condition affecting children. There's over 1 million children in the UK that have treatment for their asthma currently. And actually, the UK has some of the worst outcomes for childhood asthma in Europe, as you can see from this graph. So we've got so much work to do, and we really feel that the kind of personalized medicine approach is something that's going to really help us push that forward. So as Somnath showed you, this is the current approach, the guidelines, everyone gets the same thing. And as your symptoms get worse, as things get more challenging, you move from having a reliever inhaler, the blue one, which some of you may well have used, and you'll certainly have seen your friends and colleagues use at school, I'm sure, that has a short-term benefit and helps just relax those airways. And then you've got these actions that try and stabilize the symptoms and try and decrease the inflammation that are used on a daily basis. And as you can see, this is just a small selection of those that can be used. There's inhaled steroids that decrease inflammation. There's inhaled steroids with a longer acting version of the salbutamol in it that can decrease inflammation and relax those smooth muscles, open those airways. And then there's something called a leukotriene receptor antagonist, or something called montelukast, that can help decrease the inflammation through the leukotriene pathway. And these are just 3 of the common medications that are used. Now, this is where we're kind of moving on and just thinking. So now we've kind of got our heads around asthma. This personalized approach, this genotype-directed therapy that we've been talking about. And what we see in clinic all the time is that some asthma medications work really well for some patients and not for others. And what we're learning to understand is actually our own individual genetic differences that may explain this medication. And that's why this kind of one-size-fits-all approach just really doesn't work. Giving everyone the same guideline therapy just doesn't work. And that, but this concept, what is personalized medicine? Well, it means targeting the medicine to the individual. So you make, individual knowledge of their genetics or environment or lifestyle, and then you can direct the treatment that's individual for them, that's going to work for them specifically. And the second concept, genotype-directed therapy. So that's looking at someone's specific asthma-related genes in what we do to try and guide their treatment and give them the best possible outcomes. So where have we got to with this? Like, how far have we moved along? And again, looking at specific examples. So the purple puffer you can see there, and again, you may well know people that have been on this kind of medication, the combined puffer of the steroid and the long-acting beta-2 stimulant has been shown in trials to be the best medication if you look at the whole population. But what we know is that actually there's individual genetic differences in that beta-2 receptor that medication works on, that the blue puffer works on. And there's a great study which has recruited different populations from all around the world, so over 4,000 children. And what we know is that about 1 in 7, 16% have this ARG polymorphism that makes a change in this beta-2 receptor that this medication works on. And what we know is that even though this purple puffer, and we've got good data that shows it's the best for the whole population, for this 1 in 7, for this 16%, actually them having this medication makes them worse and increases their risk of asthma. And another follow-on study showed that actually for these people, if you identify them, that they've got these specific genetics, and you switch them from a medication that we know is best for the whole population to this leukotriene receptor antagonist that actually on the whole population doesn't work so well, actually they do much better. And so we're personalizing these asthma preventer medications on the basis of their beta-2 receptor genetics. So we've got some nice proof of concept, and Somnath led a study, a trial. So when you're trying to prove things work, having a randomized clinical trial is the best way to do that. And Professor Mukhopadhyay led the trial looking at young people, 12 to 18-year-olds with poorly controlled asthma, and looked at guiding treatment either by they're randomized to standard care by the normal guidelines or by their genotype, and their asthma preventer medication was then determined by their genotype. And it showed that those who had the genotype-directed care, had their medication, their preventive medication chosen on the basis of their genes, had an improvement in their asthma-related quality of life, which is a really important thing, how they individually experience their asthma. And we're collaborating. So trials in young people are difficult to do. They're hard to recruit to. They're expensive. And in the modern world, we collaborate internationally. So we work with colleagues in Holland and Switzerland to combine data to try and increase numbers to give us a better idea of what's going on and try and really demonstrate the power of what's going on. And what you can see is that when you go by this genotype guided care instead of the standard care, you get a significant improvement in reducing their asthma exacerbations and keeping them well. So this is really groundbreaking data. It's not been published yet. It's going to be presented shortly. So where have we got to in kind of implementing this? It's fine having this trial data, but are people benefiting? How far? How close are we to getting this into routine practice? And there's something called the Pristine-2 study that we're doing here that's looking at rolling this out into an asthma clinic. And basically we're getting there. So we've shown that it's beneficial with the studies. We've shown that it's feasible and we can roll it out into clinic. And ongoing work from the group is showing that actually this is what people want. People understand the concept of personalized medicine, having something that's unique for them. And the next step for us really is demonstrating that this is really beneficial in terms of cost effectiveness. And that's what we all want, is that actually, doing this genotyping that shows a real benefit and saves money by being precise in what we're doing, and rather than giving everyone the same medication and people being poorly controlled, that the cost of doing the genotyping actually is offset by improved clinical outcomes. And once that's been shown, then moving on to embedding that within the NHS will be the next step. So we're making progress, but there's still a lot of work to do. And there's still a lot of people that don't even understand the concept. So work to do, but really promising. So next for us is, like I said, is the economic evaluation. Then actually, well, we know that asthma is an incredibly complicated disease with hundreds of genes involved. So rather than looking at just one, we're going to be, extending that and looking at much more and trying to be even more precise with what we're doing. We need to keep engaging with the public, keep talking to people, keep educating about this approach and its efficacy, how well it works. And then look to increase the data, strengthen the data, produce more studies that will really strengthen the argument that this is the best way to manage young people's asthma. So from my perspective, this is last slide really, and so any kind of questions that come up from that, or I hope that kind of made sense.
Excellent, lovely. Thank you, Tom. Thank you, Somnath, for your presentations. I think what we'll do is I will just very briefly share a couple of slides to finish up. But in the meantime, if anybody does have any questions, please pop them in the Q&A or on the chat, and we'll try and get through as many of those as possible. We've got just under sort of 15 minutes or so to answer those. But yeah, I'll very, very quickly just pop up my own slides for some upcoming sessions that you might be interested in. So just give me 2 seconds and I'll get those up. Okay. Lovely. Okay, fab. So yeah, so if you're here tonight and you're thinking about going into medicine, something you're wanting to pursue, we have some upcoming events. Crucially, you've missed a couple of them, getting into medicine and what it's like to be a medical school student. But tomorrow night, if you are thinking of applying to medicine this academic year, we have a session all about medical school admissions tests, specifically the UCAT, that we'll be looking at in a lot of detail from from 5 to 6:30 p.m. We then have our virtual open days. So if you are interested in BSMS as a medical school and you want to find out a little bit more about us, you can come along to our virtual open day next Thursday. That's the 11th of July. That's on at 5:30 p.m. via Zoom. Sorry. This is our last monthly lecture of this academic year. We will be back in October with the next monthly lecture. We take a little break over the summer and September, but we'll be back in the autumn with another full suite of monthly lectures for you for next year. So do keep an eye on our social medias. So our Instagram, our Twitter, or X as it is now, for updates on when our next lectures are. And you can always ask if you think of any questions after tonight as well that you might have. You can send us an email to outreach@bsms.ac.uk. Lovely. In which case, I think, and we'll send you out an email with the link to the recording for tonight, but also to some upcoming events that Onesizefits1 are delivering over the coming months. So you can definitely try and come along to those as well. In which case, I think we've had some questions come through, which is really good. I will stop sharing now, and we will try and answer as many of those as possible in the time that we have. So I don't know if Tom or Somnath, you want to answer what's the most fascinating thing about being a pediatrician? Oh, I think you might be on mute there.
Tom, you want to have a go?
Yeah, I mean, I think the original question we had, which is kind of why do pediatrics, and I guess it's maybe quite closely linked with that. I'd say it's an incredibly rewarding and satisfying career. Like, children don't deserve any of the things that have happened to them, and they're incredibly robust, and you can fix them a huge proportion of the time. They're such fun to engage with. You have a huge amount of fun, but it's also incredibly diverse. You literally are looking after people, little preterm babies who are born 4 months early, who might weigh 400 or 500 grams, to teenage rugby players who, are adults and are bigger than you are and have a huge amount of things going on in their lives. And it's incredibly diverse. It relies on, really good clinical skills, really good communication skills to be able to, appropriately, interact with these families and the young people and get a good outcome and get their confidence in talking to you. And it's a fantastic environment to work in. Like, the Children's Hospital is wonderful. The people that work there are great, and we have a really good community there. And I can honestly say, if I had all my time again, I really wouldn't do anything different. I think it's fantastic.
Absolutely. I couldn't agree more with all that Tom has said. It's an incredibly reward. I think there are very few people who do pediatrics and come to any stage of their career and look back and say, oh, I don't think I have enjoyed it. It's very difficult not to enjoy spending time with children, particularly children who are in difficulty, who are suffering, who will thank you from the bottom of their hearts for getting them better.
Excellent. We've got a really interesting question in the chat that I'd like to posit to you both, because it's a really good one. If you were in control of NHS funding and could do one change in management/treatment of asthma and another one change to management of the NHS, what would it be? Oh, it's a very big question.
Okay, less management heavy.
What do you mean by that, Somnath?
Well, I've been working in the NHS for a long time, like almost 40 years. We had much less of management there. Less money was spent on management. More of the control of the NHS was in the hands of doctors and nurses. And I think it ran a lot more efficiently. And then there was this massive tier called management that was put in place, and that has grown and grown and grown and grown to a point where it sucks in a huge amount of money and there is little control over the process through which it is growing. And somebody has to tackle that. It might be you guys, because we can't anymore. We have failed. We don't seem to have a voice. We as doctors, we are trying to do our job as best we can, but I don't think we have been able to stop this from happening. I don't know what Tom feels about it, but that is, if you ask me about one thing, I'd say that.
Yeah, I mean, I think that's a significant issue. To say, you know, what one thing would you do? You know, we're in a really challenging time at the moment with the NHS and waiting lists and staffing issues and issues with primary care, and it's going to take a really coordinated approach and some long-term funding and long-term strategy to try and deal with that. And I think one of the key things really is trying to depoliticize the health service. And what we've had over a prolonged period of time is different prime ministers and then politicians coming in and trying to reorganize and restructure. And actually, if you're looking, you know, the NHS and health is such an important component of everyone's lives that actually you probably should be looking more broadly and you know, having a commission like multi-party commission set up to try and look at these long-term things, because you know, public health strategy takes such a long time to come to fruition and take such coordinated action across social care that it needs to be probably outside of the political domain, really, if you're talking about funding and securing long-term objectives. But things go through cycles in the NHS, and there's been times of feast and times of famine, and you know, we can be optimistic hopefully in the future that yeah, there will be further investment, and hopefully we should see, you know, improvement in the future. And I think personalized medicine can be, you know, a big component of that.
Excellent. Well, if anybody else has any questions, please do pop them in the Q&A or in the chat. I have a question that I'll ask in the meantime, because you spoke a lot about asthma, but I don't know, has the one size fits one approach been looked at for any other conditions? Is there any anything else that it can be used for, or is this just a general thing that it could potentially be used for anything?
If you're asking me, it's not my view. Everyone feels that it can be used for everything, for every area of medicine, essentially. Some of the areas where it has been more successful is cancer. So cancer, you have one size fits one coming in at a more rapid pace than almost anywhere else. And that is because you need to give medicines for cancer here and now, and there is a lot of pressure on getting it right and making it work at that particular moment, because we all know what's going to happen if the wrong medicine is chosen. So there has been greater progress in cancer genetics, not so much in children, but much, because of course cancer is a lot more common as a general disease. It's a lot more common in grown-ups, more in adults. In fields such as lung cancer, for example, it has made greater progress. So yes, there are some areas like cancer, but chronic disease in general, which is obviously a lot commoner. Chronic disease is much more common than individual cancers. And chronic disease is an area where the one-size-fits-one approach, where precision medicine is trailing behind. Yet the leaders of the NHS, the leaders of the world, are saying that's where we need to make progress. So here is the challenge that I will throw to our young budding would-be doctors. Can you make this happen?
Excellent. Well, unless anybody else has any other questions, thank you so much to our speakers this evening. It's been a really fascinating lecture. We're always interested in we've had lots of talks about like pediatric medicine this year, and it's really interesting to hear this side of it as well. Thank you everyone for coming along this evening.